Get started for the interest of time. Our next speaker is Dr. John Einck, and he will be speaking to us today about the changing scope and delivery of radiation therapy for locally advanced breast cancer. Thank you, Dr. Einck.
Thank you very much. I would also like to thank the organizers of now this fifth biennial GHOS conference. It gets better every year. I think the quality of presentations and the amount of information that we're learning gets more each year. Is this for advancing the slides? Okay. So what I really want to focus on today are changes that I've seen in the last 5 years of my practice that I think have led to improvements in the quality of life of our patients. In 1998, I think those of you that treat breast cancer know that there were 2 sentinel studies published showing the value of post-mastectomy radiotherapy that showed not only a local control benefit, but also a disease-free and overall survival benefit in women with node-positive disease. And there was a meta-analysis of randomized trials of regional lymph node radiation much more recently, showing a reduction in breast cancer mortality and all-cause mortality in those patients. So what's changed? Well, over the last 20 years or so, we've seen less surgery. We've seen a decreasing use of regional nodal radiation and PMRT. We've seen changes in fractionation, and we've seen changes in the use of bolus. So I want to talk a little bit about each one of those today. So in terms of less surgery, the role of sentinel node biopsy versus axillary dissection in patients with node-positive disease has changed dramatically. So we all know we're seeing a lot more neoadjuvant chemotherapy use in our breast cancer patients nowadays, particularly in those with locally advanced disease, because it has a number of benefits. The benefits are downsizing of the breast disease to allow for more breast-conserving surgery. We're better able to determine long-term prognosis of patients based on their response to neoadjuvant chemotherapy. And I think probably the most important is women who have positive nodes at diagnosis, we're downsizing the axilla. If they become node negative, it allows for less extensive axillary surgery, and that's led to probably one of the biggest improvements in our long-term patients' quality of life. In terms of, again, the benefits of neoadjuvant chemotherapy, again, I think the most important outcome has been no axillary lymph node dissection for our patients. And really, it's predictable when we're starting out treating these patients, who's going to respond to neoadjuvant chemotherapy and who's not going to. And this is sort of a chart I threw together with just sort of off the top of my head ideas about who responds to chemotherapy. Our general garden variety ERPR positive HER2 negative patients really have a pretty low chance of having a complete response to neoadjuvant chemo, about a 10 to 15% chance. Our ERPR negative HER2 positive patients have a much higher response rate if anti-HER2 agents are used, so upwards of 75%. And then recently, we used to quote about a 50% complete response rate in triple negative patients, but with the use of immunotherapy in these patients, that response rate has improved to about 75% as well. There's also a subtype of ER/PR positive patients that have weak PR expression and high proliferative indices that may also have higher responses to chemotherapy. So there have been a couple trials that have looked at the use of sentinel node biopsy in patients who've received neoadjuvant chemotherapy who have positive nodes at the outset. This is one, the ACOSOG Z1071 trial, looked at over 1,600 women with N1 to N2 breast cancer who received neoadjuvant chemotherapy. And then they did both a sentinel node biopsy and axillary dissection on their patients. And in 39 patients, the sentinel node was negative, but the cancer was found in the axillary dissection. So the false negative rate was kind of high. It was 12.6%. And so remember that the gold standard for a false negative rate should be less than 10% in an accurate sentinel node biopsy. But they found in this trial if 2 or more nodes were removed that the false negative rate did drop to less than 10% with the idea, so let's remove more nodes. But as you know, you can't always choose who's going to have a hot and blue sentinel node. Some patients may just have one node that you can remove. A second trial that was very similar called the Sentina trial randomized 750 women. Again, underwent both sentinel node biopsy. It wasn't randomized. They underwent both sentinel node biopsy and axillary dissection. And overall, if only one lymph node was removed, they had a 24.3% false negative rate. But if 3 or more lymph nodes were removed, the false negative rate dropped to less than 10%. So overall, there is an acceptable false negative rate if 3 or more lymph nodes are removed. It offers patients the ability to avoid axillary dissection, and the response rate is predictable at the onset based on breast cancer subtype. So instead of a 15 to 20% risk of axillary lymphedema in the upper extremity, the lymphedema rate is now less than 10% for these patients. So there was also a recent randomized trial that was presented last year at the San Antonio Breast Cancer Symposium that I think has changed our field dramatically. The NSABP B51 RTOG 1304 trial randomized patients with clinical T1 through T3 disease and N1 M0 who had a complete response to neoadjuvant chemotherapy to either regional nodal radiation or no regional nodal radiation. They could have breast conservation, they could have mastectomy, and if they had mastectomy, it was all or nothing. If they converted to node negative, they didn't have any radiation. If they had breast conservation, they were randomized to breast only or breast plus regional nodal radiation. So this is what they treated when they treated. They treated the breast, they treated all axillary levels, supraclav, and upper 3 internal mammary spaces. And looking at the baseline characteristics, you can see under tumor subtype, they were pretty much equally split between triple negative, ER/PR positive, HER2 negative, ER negative, HER2 positive, and ER positive, HER2 positive. And equally split between, they were stratified based on what kind of surgery that they had. So they looked at the primary endpoint, which was invasive breast cancer recurrence-free interval, and it showed it was exactly the same whether they had regional nodal radiation or not. In terms of isolated local regional recurrence, there were a few more local regional recurrences in the no RNI group, but it wasn't statistically significant. And the majority of those recurrences were regional. They were in the lymph nodes. So conclusion was there was no difference in distant disease-free survival, or overall survival. But on exploratory analysis, the group that was ER/PR positive, HER2 negative, the outcome tended to favor the RNI in those patients. So patients, there are unanswered questions. What about ITCs? What about if we give a patient neoadjuvant chemo, we don't see frankly positive nodes, but we see ITCs? The study doesn't really answer that. What if the nodes convert to negative, but the breast still has disease? The vast majority of these patients, 80%, had a complete response in the nodes and the breast. Medial primaries brings up whether the internal mammaries could be isolatedly involved, even though the axillary nodes convert to node negative. What if they have internal mammary disease? And what about the trend toward improvement in the RNI group if they had ER/PR positive, HER2 negative? This study doesn't answer those. But I think some of the questions that are quickly coming up in a study like this is it only included N1 patients. What about our patients that have fixed and matted axillary nodes, N2 patients? or patients that have high axillary disease or disease in the internal mammary nodes at the beginning, our N3 patients. Could data like this apply to them? The answer is no, but I think quickly we're going to see some trials coming up where those patients are included. In B51, the randomization, if they had RNI, was 50 gray and 25 fractions, but fractionation's changing too. In the US, I would say 4 or 5 years ago, we were still very commonly using 50 gray and 25 fractions for post-mastectomy and for whole breast radiation. But are shorter courses of radiation as effective? Are there more normal tissue risks with hypofractionation? And what about after reconstruction? Is hypofractionation safe? So you know that even in the original PMRT trials that were published in 98 showing a benefit to post-mastectomy radiation for women with node-positive disease, in the British Columbia trial, about half of their patients had hypofractionated radiation, even back in the 90s. So this is not a new concept. But in those days, very few patients had reconstruction. So nowadays, the vast majority of our patients in the US who have mastectomy are having immediate either tissue expander reconstruction or autologous reconstruction. So unclear whether we can use data from the 90s to apply to that. So hypofractionation, I think we heard about this morning. Its fraction size is over 2 gray. In the US, that means 2.67 gray for most of our hypofractionation trials. Common is 15 to 16 fractions of radiation. The ASTRO consensus recommends hypofractionation for women over 50 with T1 to 2 and 0 not receiving chemotherapy, but that's a pretty conservative definition. If you look at the ASTRO definition or consensus for hypofractionation, there's a strong consensus, over 95% for hypofractionation, and it can be offered for chest wall patients and for regional nodal radiation with or without reconstruction. And the START A and B trials both showed that there was not an increase in recurrences or worsened toxicity with shorter fractionation. In fact, some suggestion that toxicity may be less. So what about PMRT with implant reconstruction? In 2024, there was a meta-analysis of all of the hypofractionation and conventional fractionation trials on complications after implant-based reconstruction. They looked at the incidence of capsular contracture, need for major revision surgery, and wound dehiscence, and found they were all actually less in the hypofractionation group. So I think that's quite reassuring that we're not causing patients more complications when we're using these shorter fractionation schemes. RT-CHARM was a trial looking at standard fractionation 50 gray and 25 versus 4256 in 16 fractions on 898 patients receiving PMRT following mastectomy and reconstruction. Over half also received chemotherapy, and 59% of them had implant-based reconstruction, with the other 41 having autologous. The incidence of complications, and you can see complications were defined as readmission, unplanned reoperation, capsular contracture or reconstruction failure, was 14% if 16 fractions were used and 12% if 25 fractions were used at 5 years. So there was no statistical significance, and again, another reassuring outcome for hypofractionation. So hypofractionation, I think, is indicated for breast conservation and in the post-mastectomy and reconstruction setting. We generally use 4256 in 16 fractions or 4005 in 15. Again, reconstruction is not a contraindication. We still would use standard fractionation for inflammatory breast cancer. And finally, I want to talk a little bit about just changes in the delivery of radiation other than fractionation. When I was a resident, I was taught bolus the whole chest wall for post-mastectomy patients, that the whole chest wall is at risk. And you can see that leads to complications like the one in the photo here. Megavoltage radiation is supposed to be skin sparing, doesn't give a high dose to the skin surface. So when you bolus, you end up with very red skin, risk of blistering. But it really is just the skin around the surgical scar that's at risk for harboring microscopic deposits of cancer. And when we look at recurrence patterns in large randomized trials of PMRT, we're really seeing that local recurrences are within a couple millimeters of the chest wall. To avoid the kind of picture that we're seeing here, there have been a number of recent publications. Jennifer Bellin had a nice opinion article from Harvard on the use of bolus, really saying that across the board there's no good evidence that bolus is even indicated at all, but rather than throwing it away after years of using it, that there may be some modifications of bolus that can be used. Thickness of bolus, how often to apply, and in which patients to apply it are all unanswered questions. So what we think at the University of Kansas is a really reasonable option for using bolus is we still use whole chest wall bolus in inflammatory breast cancer patients and those with skin involvement at diagnosis. But other seemingly low-risk patients should have bolus applied to the mastectomy scar region only. And I think a lot of centers in the United States are moving to this. You can use 2 to 3 millimeters every day or 5 millimeters every other day. And those are both reasonable options. And this is just a picture of what our typical 4 centimeter wide bolus over the mastectomy scar looks like. And I think if you do this, you'll find you don't see a lot of pictures of skin reaction like the one that I showed you. So in conclusion, I pushed past my conclusion slide there. In conclusion, for 26 years, we've been trying to identify groups of patients that benefit from PMRT, and in fact, more treatment was found to be beneficial. I think over the last 5 to 10 years, we have data to tell us that we can limit surgery in the axilla. We can avoid RNI and PMRT altogether in certain groups of women. We can reduce the duration of radiation therapy, and a common sense approach to limiting bolus for skin toxicity is reasonable. And these modifications undoubtedly will lead to improved patient outcomes. Any questions? I don't think so. Okay, thank you.
Thank you, Dr. Einck. Our next presenter is Dr. Simmons. She'll be speaking on ultra-hypofractionation in breast cancer. Thank you.
Good afternoon, everyone. I'd also, first of all, would like to thank the organizing committee for having me here. It has been really exciting to me to be part of such an inspiring event and also to meet such an inspiring group of people, so thank you all for that. I'll be discussing ultra-hypofractionation in breast cancer. I'll start off with some background information, and then I'll be discussing a project that we have been working on within the Hypo Africa Consortium. And then I'll continue with a project that we've been working on at the radiotherapy department of Tygerberg Hospital. And this picture was actually taken a few days ago at the Durbanville Hills area. So for those of you who still have some time to travel, it's definitely worth a visit. I have no disclosures. So the previous speaker already talked you through some changes in fractionation schedules. As we all know, also in Africa, breast cancer is one of the most commonly diagnosed cancers, and radiotherapy is one of the cornerstones of treatment. And the change from conventional fractionation to a hypofractionation already resulted in a significant decrease in treatment times. And now we are at the point of ultra-hypofractionation, in which adjuvant radiotherapy for breast cancer can be completed in just 1 week. So instead of treating 1 patient in 3 weeks, you may be treating 3 patients. So that's a step for further improvement. And regarding the evidence supporting ultra-hypofractionation in breast cancer, I'd like to discuss the FAST-FORWARD trial. This was a randomized controlled trial that compared 40 gray over 15 fractions to 27 or 26 gray over 5 fractions. They've included over 4,000 patients with a median follow-up of over 17 months. And it's important to be aware that in this trial, mostly early-stage breast cancer patients were included. The vast majority were treated with breast-conserving surgery, and none of the patients were treated with regional radiotherapy within this main trial. There is a nodal sub-study of the FAST-FORWARD trial. Inclusion has been completed for the trial, as has been the follow-up period. So results are being expected in the near future, but the results are still being awaited. So for this main trial, 5-year ipsilateral recurrence was extremely low and was not significantly different between the 3 treatment arms. And when we look at normal tissue effects, there were no significant differences between the 3 treatment arms when assessed by clinicians. And when assessed by patients, the 27 gray arm did have a significantly inferior outcome. Regarding the 40 gray and 26 gray arms, there were no significant differences. And when we have a closer look at the acute toxicity rates in this study, if you have a look at the most upper curves, you see that almost all patients in all the treatment arms experience grade 1 or higher acute toxicity. If you look at the dotted lines, the ones that are almost horizontal, the most lower curves, there was no grade 3 or higher toxicity in the 40 gray and 26 gray arms. And if you have a look at the dashed lines, some patients experience grade 2 acute toxicity, and I don't know if I can use the pointer. Yeah. If you look at these lines, you can imagine that it's relevant to make sure that you have a visit at around 2 weeks to be sure that you do not miss the highest score of toxicity in patients who are treated with 26 gray. So following the publication of the results of the FAST-FORWARD trial that coincided with when COVID happened to all of us, that resulted in a very swift implementation of ultra-hypofractionation in breast cancer in clinical practice in Western countries. However, feasibility has not yet been validated outside Western population and outside Western settings, while ultra-hypofractionation is, as has been discussed already several times this weekend, especially relevant for countries with less capacity and less resources. So ultra-hypofractionation really is an option to improve efficiency, time efficiency, cost efficiency, and this applies both to the perspective of healthcare professionals as well as to the perspective of patients. So within the Hypo-Africa Consortium, we've been working on a study proposal to confirm that ultra-hypofractionation is associated with mild acute toxicity in the African setting and population. So similar to the ultra-hypofractionation study in prostate cancer that was discussed by Professor Incroci, it's not the idea to repeat a randomized controlled trial, it's the idea to confirm that this is also associated with mild acute toxicity in the setting in Africa. And the idea is that this hopefully will be a first step towards broad implementation of ultra-hypofractionation for breast cancer in Africa. So the idea is that this will also be a prospective observational study in which patients will be included that have an indication for local therapy, radiotherapy, with or without regional radiotherapy. And regarding the regional radiotherapy, as I already discussed, we are still awaiting the results of the nodal sub-study of the FAST-FORWARD trial. However, it will be very relevant if we can use ultra-hypofractionation in patients with more advanced breast cancer, as this is the majority of the patients that are diagnosed in Africa. So if the results of the nodal sub-study will show us that it's not safe to treat regional radiotherapy in ultra-hypofractionation schedules, we obviously will change the eligibility criteria accordingly. And in the fast-forward trial, regional radiotherapy did not include radiotherapy to the internal memory chain, so that's also something to keep in mind. Regarding the endpoints, the primary endpoint will be acute toxicity up to 1 month after radiotherapy, and we will include an extra site visit at 2 weeks to be sure that we will not underestimate the severity of acute toxicity. And regarding secondary endpoints, this will include side effects at 3 months and at 12 months after radiotherapy. And importantly, we will also include patient-reported outcomes, and we will assess 5-year local recurrence and overall survival rates. And the importance of quality assurance programs has been mentioned several times already. This study will also include a quality assurance program. So regarding the sample size, the hypothesis is that almost all patients will experience grade 1 or grade 2 acute toxicity. And following the fast-forward trial results, we expect that the rate of grade 2 or higher acute toxicity will be around 20%. And following a sample size calculation by our statistician, we will need 150 evaluable patients to exclude the possibility that acute toxicity rates will exceed 30%. And as I mentioned earlier, 26 gray did not cause any grade 3 or higher toxicity within the fast-forward trial, so we want to make sure that the rate of grade 3 or higher toxicity is extremely low, less than 5%. So for that reason, we included a stopping rule regarding grade 3 or higher toxicity within the study proposal. So at the moment, the Hypo-Africa Consortium is applying for funding, and hopefully we will be able to start this trial somewhere in 2025. In the meantime, we are working on training courses for ultra-hypofractionation to make sure that centers that will be participating in the future will be well equipped to utilize ultra-hypofractionation in their practice. And in the meantime, we performed a survey on the readiness for ultra-hypofractionation among 6 leading sub-Saharan African institutions in different countries. The results have been analyzed by one of our colleagues from the Hypo-Africa group, and I'd like to share one of the figures from that work. We asked respondents whether or not they would be willing to use ultra-hypofractionation in certain scenarios for breast cancer. And as you can see that in the case of whole breast with or without boost or chest wall radiotherapy, 4 out of 6 institutions would be willing to do so. When it comes to regional radiotherapy, there's a little bit more uncertainty. And reasons for currently not using ultra-hypofractionation in clinical practice were concerns over motion management, concerns over late toxicities and lack of evidence, but also concerns regarding reimbursement have been mentioned. Importantly, some of the institutions do already use ultra-hypofractionation in selected breast cancer patients in clinical practice. So that's very good to see. So now I would like to continue to discuss a project that we've been working on at the radiotherapy department of Tygerberg Hospital with Dr. Thebe and Dr. Berger. This is also a prospective observational study. In this trial, we will just focus on patients who have an indication for local radiotherapy, so no regional radiotherapy. And the aim is to include 30 patients with a focus on making sure that there's not a high rate of grade 3 or higher acute toxicity. Again, the primary endpoint will be acute side effects with an extra visit at 2 weeks after completion of radiotherapy. And for that extra visit, patients will be reimbursed because it's not a routine visit at Tygerberg Hospital. And as secondary endpoints, apart from acute toxicity at 3 months, we will also assess radiotherapy-related time cost, so that hopefully we will not only be able to show that ultra-hypofractionation is feasible in terms of acute toxicity, but to also show the benefits in relation to time efficiency. I think you can all agree that it's not easy to get IRB approval for any type of research. Tygerberg Hospital is not an exception, but we do have IRB approval, also institutional approval. And of course, we made sure that the patient information letters have been translated to Afrikaans and Xhosa. Despite the practice of yesterday evening, I'm unfortunately not able to incorporate the clicking sound. Sorry for that. And at the moment, the first patients are being included. So hopefully in the near future, we will start to have some first data to confirm that ultra-hypofractionation is feasible in the African setting. So while working on this project at Tygerberg Hospital, we came across some aspects that are actually quite relevant to be aware of. So those I would like to highlight, starting with delineation. There are two main atlases used for delineation in breast cancer, the European one and the American one. The European one, the ESTRO one, is mainly focused on early stage breast cancer, and the American one, the RTOG one, is more focused on patients with more advanced breast cancer. However, in Europe, we do also follow the ESTRO guidelines for patients with advanced breast cancer. And there is actually a major difference. I don't know if you immediately see the difference between those two pictures. I'll zoom in a little bit. As you can see, on this side, this is the chest wall delineated following the RTOG guidelines. The muscles and the ribs are included. As in the ESTRO guidelines delineated volume, this is not the case. So if we look at an overview of differences between these guidelines, this has been very well presented in this paper. It does in fact state in the RTOG guidelines to include the muscles and the ribs. When we have a look at the protocol of the Fast Forward trial, it clearly states that for both the whole breast as well as chest wall CTV, the muscles and the ribs should be excluded. So in case you are thinking of treating patients in your practice with ultra-hypofractionation, it's important to keep in mind what they actually did in the initial trial. So regarding margins, if you have the option to perform daily CBCT, you have the possibility to decrease your margins. It obviously depends on the systematic error that you have at your institution, but the margins with daily CBCT can be as low as 5 millimeters. And that obviously makes a huge difference compared to 1 centimeter with regards to target coverage and complying with constraints for the organs at risk. And even changing from 1 centimeter to 8 millimeters will already make a huge difference. Regarding treatment planning, people who use full 3D CRT may find it difficult to comply with the strict constraints for ultra-hypofractionation. And instead of going for full VMAT, another option would be to use a hybrid technique. This is a technique we use at Erasmus in the Netherlands. And it consists of 2 standard 10 fields, 3D beams, with which we provide about 70% of the doses, and the remainder of the dose is provided with 2 additional IMRT beams. And together this actually creates a quite homogeneous dose distribution, and it makes it easier to comply with the constraints for target coverage and for the organs at risk compared to full 3D CRT. So if you want to know more about this, let me know. Hester Berger has also been very interested about it and working with it, so feel free to contact me about this. And then lastly, I'd like to discuss the breath holding technique for patients with left-sided breast cancer. Even when you have the equipment and the software to do breath holding techniques, it may be difficult and challenging to instruct patients to do the breath holding accurately. So we've been working on patient instructions, and it has been very helpful to have patients come in a few days prior to their appointment for the planning CT, so that you can practice the breath holding with them and see if they maybe do something a little bit wrong, and you can adjust that, and then you can also give them some instructions so that they can practice at home. And this has actually been shown to be very well working, and this helped to have a patient perform breath holding successfully at the time of the planning CT and during the whole treatment at Tygerberg Hospital. So with that, I would like to conclude with a take-home message. Ultra-hypofractionation in breast cancer has the opportunity to improve efficiency, both for healthcare professionals and patients. When you change to a new treatment schedule, obviously it's important to pay attention to specific aspects, as with any change in treatment protocols. And as has already been mentioned a couple of times during this weekend, if we want to show that what we are doing it well, it's important to treat patients within studies, and this can be also prospective observational studies. And with that, I would like to thank you all. I also especially would like to thank the radiotherapy department of Tygerberg Hospital, especially the breast team with whom we've been working on all these aspects. Also the colleagues of the Hypo Africa Consortium, and of course the organizing committee for this whole event. Thank you very much. Okay, if there are any questions, I'd be happy to take them. Or you can also send me an email if you think of something later on. Thank you very much.
Our next presenter is Dr. Queen Tarimo. She's a registrar at Ocean Road Cancer Institute, and she'll be speaking to us today about the prevalence of depression in newly diagnosed breast cancer patients at Ocean Road. Thanks, Queen.
Good afternoon. First of all, thank you to the organizing committee for giving me this opportunity. So I'm excited to share with you my thesis results. So I looked at a different angle, which is actually an essential component for patients' care. I looked at the prevalence of depression and associated risk factors in newly diagnosed breast cancer patients that we are treating at Ocean Road. So as we know, that depression is a serious and a common mental illness that seems to affect a larger number of patients, but it has been found that cancer patients have a 3.4 times higher risk compared to the general population. And this has been found to impact the quality of life of these patients, also extend their hospitalization stays, and even impact their quality of life. And as we all know that the diagnosis and the treatments of breast cancer are often very traumatic to patients and can subsequently lead to a lot of psychological reactions like sadness, which can contribute to the poor treatment outcomes. So the main aim of this research was to try and improve the clinicians' awareness, but also try to reiterate the role of psycho-oncologists in the cancer care, but also improve the treatment outcomes of these patients. So the objective was to determine the prevalence of depression in newly diagnosed breast cancer patients, but also to determine the severity, and we looked at factors that were associated, where we looked at the clinical factors, but also we focused on socio-demographic factors like the age, the economic status, whether or not they had the insurance, and whether or not they had adult care responsibilities. So this was a hospital-based study. It was a cross-sectional study which was conducted at Ocean Road, and we included female breast cancer patients that were above 18 years that were newly diagnosed with confirmed histology. This study took a period of 4 months, and the tools that were used, we used the Patient Health Questionnaire tool for depression, which is a validated tool to be used in chronic illnesses like cancer. And we grouped our patients into 2 groups. So we had the first group where we have the patients had minimal to mild depression, where they scored less than 10. And then we had another group where we had patients that had moderate to severe depression. These are the patients that scored more than 10. So looking at our results, the first objective was to determine the prevalence. So we can see that more than half of our patients were found to be depressed. And this is already, it just adds to the body of existing evidence that shows that depression is quite common, and especially to newly diagnosed breast cancer patients. However, this prevalence has been very high compared to the general population, which is around 4 to 26%. So we also looked at the severity of depression, where we can see that we have mild, moderately, and moderately severe. So our patients were falling in the mild and moderate group, which has been consistent with other literatures. However, the numbers in the mild and moderate group, as we can see, for the mild group, we have about 40%, moderate, we have 10%. In comparison to other literatures, we have a bigger number or a bigger percent compared to other literatures where they have a very lower number. So this is a slide to show the factors that are associated with depression. Amongst all the socio-demographic factors that we looked at, only age was found to be associated with higher depression scores. So we can see patients that were less than 45 years of age were 2 times more likely to have higher rates of depression compared to the older patients. And this could be explained by because these patients have worries about their career disruption. Also they've not accomplished their families, and also their coping strategies is not as the older patients. Also, the clinical factors that we looked at were the stage of the disease, which was associated with higher rates of depression. Patients that had higher advanced stages of disease were 3.4 times more likely to have depression. But of interest is that patients that had not received surgery at the time of interview were 6 times more likely to have depression. So this has been very different in comparison to other studies where patients that underwent surgery were found to have higher rates of depression. And I can explain this because I think in our population, surgery is linked to a more proactive approach and the potential of cure. So I think the patients that were still awaiting treatment found themselves to have more worries, more sadness, and maybe this could explain the finding. Also, we have HIV-positive patients. These patients were 10 times more likely to have higher depression scores, and the patients that presented with pain, particularly with symptoms, particularly pain, were also found to have higher rates of depression. So in conclusion, we can see that the prevalence of depression that we have seen, it just adds to the already existing body of evidence, which actually calls for realization of this in our day-to-day activities so that we can integrate the role of psycho-oncologists or psychologists in our routine treatment or in our routine care of our cancer patients. But also we have managed to see the vulnerable population, the young patients, patients with advanced stage, those awaiting treatments, and patients living with HIV that actually need added psychological support. And finally, I would want to, we can also have peer navigator programs where we can have trained survivors or patients that had similar experience coaching or providing guidance to patients so that they know what to expect. Thank you so much for this. Any questions? Thank you.
Thank you, Dr. Tarimo. We'll move forward with our next speaker. We'll be hearing from Dr. Ireen Chanda. She is a registrar at Lusaka, at the Cancer Disease Hospital in Lusaka, Zambia. And her talk is focused on the epidemiology and clinical outcomes of de novo metastatic breast cancer. And she'll tell us about their hospital's experience.
So thank you so much. Good afternoon, everyone. My name's Ireen Chanda, and I'm a radiation oncologist from Cancer Disease Hospital, which is the only referral cancer center in the country against a population of 20 million individuals, and with a background of only 20 oncologists. Okay. So I've got nothing to disclose. So the background is late presentation of breast cancer contributes to current burden of disease, as we all know, and is quite a a significant public health concern in that we've seen quite an arising in incidence and mortality, especially in the sub-Saharan region. And of note is countries like Zambia lack information on characterization or epidemiology as well as the clinical outcomes of patients that present with advanced breast cancer. So locally generated evidence will inform critical intervention as well as result in policymakers to actually strengthen our healthcare system by prioritizing screening tools as well as allocating more resources towards the fight of breast cancer. So the objectives of the study were basically to describe the clinical pathological characteristics of patients that present to the cancer center in Zambia, also to evaluate patterns of treatment of de novo metastatic breast cancer over the 10-year cohort period, as well as to analyze the survival of patients with de novo metastatic breast cancer, as well as just to appreciate the prevalence. So the methods, basically it was a retrospective descriptive study, which was conducted at CDH, which is the only referral as well as oncology center, and patients with proven or confirmed biopsy seeking care at the institution were analyzed from 2010 January to December 2019. And secondary data was extracted from the already existing Susan G. Komen project, which is a big data for breast cancer and cervical cancer. And variables that were analyzed were social demographic, patient characteristics, as well as tumor-related factors. Women with proven breast cancer histology above the age of 18 years were included in the study, and men were excluded from this study. It was a descriptive study, so descriptive statistics using proportions, ratios, as well as percentages and survival analysis were used. So these are just some of the preliminary results that were extracted from this study. So as we all know that age is a contributory factor to late presentation, so we wanted to see if this tallied with what we already know. So what we saw is, we saw that we had a bigger proportion of patients between the range of 45 to 65, representing a percentage of 40%, which is in conformity with the literature that we already know. Then since we are trying to analyze the socio-economic or socio-demographic status in a low-resource income country, wanted to see if marital status has an impact on late presentation as well as seeking health treatment. So what we saw is about 54% of our patients were married, and those others showed that patients' marital status were either single, divorced, and I have to make mention that we have quite a lot of missing data, as you are going to see from most of the results that we have, and reason being Zambia is a low-resource income setting. And then the other thing is the number of oncologists that we have is very few. So most of this data of the clinic clicking was done by general or house officer doctors who did not follow the protocol for assessment or even for taking into consideration the risk factors. So age at MENAC also was analyzed because we know that some literatures have shown that MENAC below the age of 12 poses as a risk factor for patients presenting with advanced disease. But as you can see from our data, we've got a huge gap where we have a lot of missing information where it wasn't collected. And then I wanted to also look at parity to see if at all there was an association between the nulliparity or the number of children that one had in relation to them either having an increased risk of them presenting with advanced breast cancer, for which we know that patients that have children above 5, previously we knew that they had some kind of protective factors because of low exposure to estrogen. Then we also just wanted to also look at the risk factors for developing breast cancer in relation to patients presenting with advanced stage. So contraceptive use was also analyzed, but what we're seeing is a bigger proportion of patients could not be accounted for in terms of whether they use contraceptive or not. And what we've seen also with risk factor concerning the family history, because we know that certain family histories of malignancies tend to actually pose a risk for developing advanced breast cancer. So we are trying to look at patients that have got relatives that either had a prostate, breast, as well as ovarian, which we couldn't extract. Then when it comes to, wanted to analyze also which patients would actually present with an advanced stage of breast cancer between the premenopausal and the postmenopausal. So what we saw is we had a large proportion of patients in the premenopausal that presented with breast cancer, which was about, if we add them together, 33 plus 4%, which was coming to almost 37%. Premenopausal women presented with breast cancer at an advanced stage. But again, we've got this large portion of 94 women that were not accounted for. So we see that the Susan G. Komen had actually these gaps. And then also we know that patients with comorbid condition, especially in the ABCD study, showed that there was a strong correlation between patients' poor outcome who were HIV positive as opposed to the HIV negative population. So in our study, what we saw was from the 365 patients that presented with de novo metastatic breast cancer, only 73 were HIV positive. So again, the data didn't tell us if these patients were on treatment and what was their CD4 count. Again, we have these 38 patients whose status was not accounted for. The 94, these are patients that did not know their status at the time of presenting to the hospital. Then on tumor characteristics, looking at the T stage, clinically, these are patients that we anticipate to present with large tumors in our clinical setting. So what the study showed was, again, we had a bigger proportion of patients presenting with the T4, clinical T4 disease, which was representing a 61.9%. And this is what actually we see in our clinical practice every day. Patients walk through our clinic for the first time with huge masses, so we just wanted to appreciate what other factors in terms of tumor biology would actually pose them to actually present with de novo metastatic breast cancer. Then in terms of the lymph node status, again, we saw that we had a proportion of 38% presenting with N1. This is the clinical exam. Then I have to make mention that we've got quite a number of gaps when it comes to clinical examination, because during this time, when patients were coming to our facility, our hospital was operating as an outpatient department, meaning that these patients were being referred from the surgical wards as well as being admitted. So by the time we're seeing them, maybe some form of maybe mastectomy, but they always indicate that it was actually, they used to call it simple mastectomy or toilet mastectomy was done. That's the essence why you're seeing the TX as well as NX. Then when it comes to histology type, what we see is a large portion of patients had invasive ductal carcinoma, which was representing 87.1, and we had one patient representing 0.28 who presented with high-grade DCIS. So this is a patient that was followed up, and later on with subsequent CTs as well as chest X-ray, she was found to already be metastatic. Then I have to mention that when it comes to immunohistochemistry, as we are going to see, we've no data on the grade 1 tumors, if at all there were any. The reasons are that most of our patients lack insurance health cover. So during the time for the study, most of the IHCs were done by a partner who would actually maybe just sample a few cases. So I find that we do not have much information on the receptor status, of which the picture is different, because from 2021, the government took it upon itself to actually have every patient or every cancer patient on the health insurance policy, making it easy right now for us to actually do all the IHCs. So from the study, we see that 27.4% had a grade 1 tumor, and then we again see this huge number of 177, representing 48.9, not being able to actually have the grade reported. Then in terms of the KI proliferative index, same with the receptor status and estrogen and progestogen, we see that we have a lot of gaps because only few patients were being able to actually have the donor partner support their IHCs. So what we're seeing is we had 65 patients out of 365, representing 17.8, who were estrogen positive, because we wanted to analyze which molecular subtype or which patient tend to present poorly or even fare poorly. Does it mean that our triple-negative breast cancer patients seen in Zambia who actually fall in conformity with what we already know, that patients with triple-negative breast cancer tend to actually fare poorly, but we couldn't answer those questions because of the missing data that we have. So again, treatment, we also wanted to look at trends in treatment. So what we've seen is most of our patients presented with a very good performance status, meaning that they were actually good candidates for us to actually give them treatment. And what the cohort showed was most of our patients received some form of treatment. So we have 281, representing 76.9, receiving systemic therapy, of which this was chemotherapy. And then of the 281, because we had 11 patients that declined treatment. So of the 281, again, we see that 90% actually received multiple agent kind of chemotherapy. And we manage our patients in a multidisciplinary team. So for some of the patients that we are seeing, they received some form of palliative surgery in the form of simple mastectomy. And radiotherapy that was given to 73% of our patients actually showed that most of these patients received the fractionation dose of 20 gray in 5. Okay, then when it comes to follow-up and clinical outcomes, so what this cohort showed is from the data that we had, we were able to come up with a median follow-up of 5.4 months. And we also saw that at follow-up, we had 67 patients, which translates to 18.6 who are stable with disease, and then we see 50.1 for progressing. And then we have quite a huge burden where most of our patients, we tend to lose them, so in terms of loss to follow-up. So these are some of the patients that we couldn't account for them, and then only 21.64 patients died from breast cancer. These others, we cannot account for their deaths because they come from quite far places, so it's very difficult for us to follow them up. Then this is just showing the proportion of breast cancer during the cohort period, which is average about 22%, which is almost in conformity with what we see in literature about de novo metastatic breast cancer in low resource income country, which is between 30 and 47. Then in terms of survival, we wanted just to compare between the premenopausal and the postmenopausal. So what we saw was there was no difference in terms of survival between the premenopausal and the postmenopausal women. And then in conclusion, from the study, we were able to generalize that about 22% of patients present with de novo metastatic breast cancer, and the median survival of our patient was 5.4 months, and there was no significant difference in terms of survival between the post and premenopausal women. And then we have a lot of missing data on most of the variables. Hence, the recommendation was there was need for us as an institution to conduct a prospective study to actually answer the number of these missing variables. And those are just my, acknowledgements to the people that we've been working with. Thank you.
Thank you, Dr. Chanda. Our next speaker is Dr. Kashveka. She's also a registrar from Cancer Disease Hospital in Zambia, and she'll be speaking on bridging care gaps for cancer patients in Zambia.
Okay. Thank you so much, and good afternoon to everyone. I hope we're still awake. So I'm Mizi Kashveka. I'm a clinical oncologist from Cancer Disease Hospital, Zambia. And I'll be presenting on, this is actually a prospective study that we want to do on bridging care gaps for cancer patients in underserved districts and provinces in Zambia. And I think this should help us understand from what Irene presented on why we had 77.3% loss to follow-up breast cancer patients. This should help us understand, and what we are looking at is to see how we can bridge that gap. Why are we having a big number of patients who are lost to follow-up? Okay, I have no disclosures. So the background of this, so I hope I'll be able to, okay. So this is just a map of Zambia. Okay, so Zambia is in Southern Africa, and the Cancer Disease Hospital is the only cancer center we have in Zambia, and this is where it's located. It's located in Lusaka, the capital city of Zambia. So we have patients who are coming from very far places, and most of these places are rural places. So all this far, this is where our patients are coming from, and we get to see them in the Cancer Disease Hospital. This is where, when they are diagnosed, some of them maybe will be diagnosed if they are surgeons to do biopsies. Once they are diagnosed, they are sent to the Cancer Disease Hospital. That's where the workup is done. They are staged and treatment is done. Chemotherapy, radiotherapy, everything is done at the Cancer Disease Hospital. So currently, the plan is to build 2 more cancer centers. So there's one that will be built in Livingstone, and the other one will be built in Ndola. So the one in Ndola has already started. It's being built currently. So the issues that we have are that since patients are coming from far and these patients have challenges with finances, so there are just lots of challenges that they face. Once they come from all these far places, some of them will have to admit them for metastatic workup. When we stage them, it means when we make a plan for their treatment, we give them, either we start their treatment there and then, or we make a plan on whatever treatment we are doing. So when those plans are made, if the patient is getting radiotherapy, it means we have to admit them, because if they are coming from far, they would not manage to come for their treatment. We admit all these patients until they start and finish all their treatment. And the space is limited. That means the ones that will have to be going back are those patients who are on safe chemotherapy, depending on what regimen they are on. They'll have to return to their places where they're coming from and return. So the issue that comes in is those that go back, how many are going to come back for treatment, to continue their treatment, how many are going to come back? And so these are the challenges that we're facing. So that this is why we want to have this project done, so that we see what challenges our patients are facing and see how we can bridge that gap. And the issue that we want to look at is to see how we can strengthen the already existing hospitals in these centers to give support to these patients, so that we are able to continue with follow-up. We don't have lost follow-up patients, and also to just get the psychosocial support, the palliative support that the patients need, because some patients will be diagnosed in these areas. They will not be told they have cancer. So some will hold on to their histology report. 2 years later, you come and see them coming with their report, their disease would have advanced. So if we have support from all these hospitals, because we have hospitals in all these districts across the country, but what lacks is the care for cancer patients. The only care they know is cancer diseases hospital. So if a patient leaves and they have a challenge while they are in wherever they are coming from, the first thing that the doctor thinks of is sending them back to cancer diseases. So some things can be sorted out while the patients are already in their towns and districts. So for this project, it's going to be a 3-phase project. So what I'll be presenting today is the first phase of the project that we want to do. So of note in literature, of note is that social determinants of health do affect cancer patients' related quality of life. And also, this leads to delay in diagnosis and also treatment initiation for these patients because of the reasons that I just highlighted on the challenges that the patients actually face in our country. So some of these challenges, like I said, they are really pronounced for these patients that come from very far from where the cancer center is located. And also of note, from our National Cancer Control Strategic Plan, it highlights a gap that we do not have any focal persons in all the other districts in the country. The only care facility that's there for cancer is screening for cervical cancer. So we're hoping that once we strengthen, we're going to have all other cancer types being helped in different cities. So this is just showing us what we have in Zambia. So this is from Global Can Zambia 2022. So the population for Zambia was at 19 million. 470,238, and new cancer cases that were seen in 2022 were 15,296. So these are the 5 top cancers that are there, and the graph is just showing us how many patients accessed palliative care services. So as we can see from the new patients that we have, these are the only ones that were canceled out of the 15,000, which represents about 7%. And social services, only about 7%, only about 3% were able to access social services. So the aims of this study will be to create a needs assessment questionnaire. So currently there's a validated questionnaire, the CMS Health Related Social Determinant 2, which was used on cervical cancer patients. So for this one, we just want to edit and add a few more parameters that we want to include for all the other cancer types. And also want to determine the unmet cancer patient needs. And so what will this study add value to the country? So it's going to help us uncover the unmet cancer patient needs for Zambia. It will help us mitigate the healthcare disparities that are existing. It will help us enhance the psychosocial well-being of our cancer patients. It also to improve treatment adherence and outcomes for our patients. And this will therefore lead to strengthening of the healthcare system because our patients will be able to access these services from wherever they're coming from, as close to home as possible. And also to provide a platform for data collection for health-related social needs for our patients, and also to help our patients access comprehensive cancer care from all these provinces where they're coming from. So it's going to be a prospective study, and the site will be the Cancer Diseases Hospital. And the inclusion criteria will be any patient who's aged 18 years and above, which is going to be patients with a confirmed cancer diagnosis at any stage and any type of cancer. And these patients should be patients that we are managing at the Cancer Diseases Hospital. And also patients that are residing in the underserved districts and provinces. So we also want to include the caregivers for the patients with the criteria that I've just mentioned. We want to include the healthcare workers in these underserved provinces to see what needs they have, how we can strengthen their systems that are already existing. And we are going to exclude patients who have already received financial and psychosocial support, patients from private hospitals or abroad, because we do not have much control on what's happening to them, and also non-Zambians, because non-Zambians have to pay for their health care in the country, and anyone who's not willing to participate in the study. So the plan is to collect the data, and we're hoping to train at least the data collectors over at least a period of 3 to 4 months, and we would want to at least have about 150 patients data collected, 150 caregivers and 150 healthcare workers, and it's going to be a rapid qualitative data analysis. So this is just showing the Gantt chart, and we're hoping by this time around next year, we would be having results done already, and the study would be completed so that we move to the next phase. So some of the pitfalls that we are anticipating are that we do not have protected research time because we have very few oncologists. We are about maybe 13 in the whole country, and some are in management. So it means you cannot have protected time just for research. So, and also the other issue is people willing to participate in the study, if that is going to be a challenge, and also funds to carry out, hoping that we will source funds locally and internationally to fund to do. So the future plans, like I said, this is the first phase. We're going to have the second phase where we are going to plan after we get our data and we know what challenges are existing, so that they will guide us on how we're going to plan, and also how we are going to, the third phase will be implementing the actual study. Thank you. Any questions? Okay, thank you.
Thank you, Dr. Kashveka. So now we have another break, 20-minute coffee tea break. We ask that everyone please return for our next session, which starts at 2:50.